Good evening, everyone, and welcome to another Sex Matters webinar. I'm Helen Joyce, the Director of Advocacy for Sex Matters, and our topic this evening is child gender medicine. How we got to a place where gender-distressed children are being prescribed drugs to halt normal puberty as a precursor to cross-sex hormones and surgery, and what the rather limited evidence tells us about the physical and mental impact of these treatments. With me, I have two panellists, sociologist Michael Biggs, who's a member of the Sex Matters board, and social science researcher Matilda Gosling, who has written two papers published by Sex Matters and is in the process of writing a third. So what we'll be doing this evening is this. We're going to start with Michael, and he's going to look at the history of how we got to here. And then we'll turn to Matilda, who will give us an overview of the current state of the evidence. And then the three of us will come back together again for moderated questions. So thanks to all of you who submitted your questions in advance. Any more can be put in the Q&A during the session for us, and we'll try to get to as many as we can. So we'll finish at 8:30, and the recording will be available on our YouTube channel shortly. All right, Michael, over to you.
Great, thanks. I'm just wait for my slides to come up. So let's begin with this quote. Puberty blockers, hormone replacement therapy, and gender-affirming surgeries have been standard forms of care for cis and trans people alike for decades. That was a sentence that came just last week in the kerfuffle over the New York Times. Some activists were worried that the New York Times was beginning to report more objectively on this issue, and they wrote this outraged open letter. I think this is the kind of myth that is maybe prevalent in the mainstream media, and I want to dispel that by talking a little bit about the historical background. In particular, I think there are three things to emphasize. First of all, that these are very recent treatments. Secondly, that they're still very experimental, and in fact, Matilda will be talking more about the evidence for that. And thirdly, just to emphasize the massive increase in the number of kids who are under 18s who are going through these medical procedures. So there's no such thing as a transgender child before the 21st century. The gender identity disorder of childhood was introduced into the Diagnostic and Statistical Manual, the kind of Bible of sort of clinical disorders, in 1980. Gender clinics for the under 18s were started, they first began to appear in the 1980s. That was at the end of the decade is when the Tavistock, what became the Tavistock, started. The first one in Europe started in Utrecht, and there was one in Canada, but they were still extremely rare. And most importantly, these clinics offered no endocrinological or surgical interventions. All they did is provided therapy until the kid reached the age of 18, in which case they could go on to adult clinics and then have various medical procedures. Next slide, please. So what we have is in the 21st century, early 21st century, we find the creation of the transgender child, this new kind of person being invented, and this is to provide some evidence for this novel creation. This is from the Google's corpus, which is all digitized books and journals and everything else that they've got from university libraries. And what you can do is you can search in the English language corpus for various phrases. I've just looked for the two-word phrase trans kids and transgender children and so on, all possible combinations. And you can see there are minimal uses of this phrase in the late 1990s and early 2000s, begins to take off in 2006, and you see a massive explosion from 2015. And of course, there are a variety of different explanations for this, but one key explanation is the invention of a new kind of medical treatment, puberty blockers. Next slide, please. And this was invented in the Netherlands. As I said, the first gender clinic for under 18s was started by Peggy Cohen-Kettenis in Utrecht in the early 1980s. And I think Peggy Cohen-Kettenis could claim to be one of the founding mothers of sort of transgenderism, along with Judith Butler. In some sense, you could say that they're both equally important. Judith Butler, very well known Peggy Cohen-Ketten is rather less so. But she was the one who really pushed early childhood transition. And I've laid out this history in my article, which appeared last year, called The Dutch Protocol for Juvenile Transsexuals, and that's open access, so please do have a look at that if you're interested in more detail. So there are two key publications that the Dutch clinicians introduced this new treatment. One is by Horan and Delamar van der Waal, The Feasibility of Endocrine Interventions in Juvenile Transsexuals. And I think that is a very important sort of phrase to keep in mind, juvenile transsexuals. They really are, that they are taking these 12-year-olds and they're saying these are juvenile transsexuals and we need to, turn them into transsexuals. The really influential article was by Peggy Cohen-Ketten in 1998, and that was a case study of the very first patient who had undergone puberty suppression. Next, please. This is called, this kid was called B, known as B in the literature. So B had always been a classical tomboy in her play activities and toy and peer preference. So she liked to hang out with boys. She liked to play with kind of boys' toys, and she wished to be a boy. There was actually a lot of conflict within the family because the father, who was rather a macho Italian guy, found evidence of his daughter's masculinity very difficult. You might like to have a guess as to what B's sexual orientation was. So what Delamar van der Waal did, an endocrinologist, did is at age 13, she prescribed B with gonadotropin-releasing hormone agonist, GnRHA. That became known as puberty blockers. And then for 5 years, B was sort of in a state of suspended animation until at the age of 18, she took cross-sex hormones, testosterone, and then she had all these surgeries and very quickly had her legal sex changed. The Dutch are very, very keen on doing the surgeries as soon as possible after the adolescent turns age of 18. So as Cohen-Ketten summarizes, the case of B is the first we know of to show that pubertal delay and subsequent hormonal and surgical intervention in a consistently cross-sex identified person has resulted in a positive outcome. And that is the case that really kind of launched puberty blockers, and other gender clinicians and other places and parents looked at this and said, this is a kind of a magical transformation. You can actually change sex in this case and create this happy passing transsexual. Next, please. So what they were using was gonadotropin-releasing hormone agonist, and that is, and I should just underline the fact that it's never been licensed for gender dysphoria, but it has been licensed to treat precocious puberty in children. It's been used to treat various conditions like prostate cancer, and also it's used to chemically castrate sex offenders. Maybe the sex offenders is the wrong word, the wrong phrase. These are men with sort of obsessive compulsive sexual obsessions. And so voluntarily they take this in order to reduce their obsessions. And what's intriguing is when you compare the medical literature on the use of the same drugs in the sex offenders or for men with sexual obsessions, they're always very worried about the side effects. Whereas when they talking about using it for children or adolescents, they don't seem to be worried at all about the side effects. So Horan, who in 1996 had said how wonderful this was as an intervention for juvenile transsexuals, was worried in the same year. He wrote another article about the use of it for treating men with sexual obsessions, and he was worried that the side effects, as he said, may be very uncomfortable. But the key advantage of early puberty suppression was, as the Dutch clinicians summarized, it results in a high percentages of individuals who more easily pass into the opposite gender role than when treatment commenced well after the development of secondary sex characteristics. So, of course, it is true that if you suppress puberty early enough, you will stop developing the sort of characteristics of male and female. So a girl won't develop breasts, and a boy won't develop a deep voice, and it won't develop lots of hair, and so will be much easier to pass when they become an adult once you add on the cross-sex hormones. So it's all about appearance. They only really care about bodies in terms of how they appear. They're not interested in what they do. So they're not interested in sexuality or sexual, for example, libido or ability to orgasm. They're not interested in fertility. They're simply interested in how well you pass. And of course, it's true that if you start early puberty suppression, you're much more likely to pass. Next, please. So just to give you an idea of how the magnitude of increase in the use of puberty blockers. So in the 1990s, it was still extremely rare. A few more kids got it after B, but it was basically one per year. And then it was codified in the Amsterdam Gender Clinic, this new protocol in 2002. And then the numbers increase, and they double, and they triple, and they quadruple, and they quintuple. And they increase tenfold, and then they keep increase 100-fold, to the point where in 2017, you get 170 kids per year being given puberty blockers. Now, we don't have any more recent figures because the Amsterdam Gender Clinic at that point was so overwhelmed by the demand for this new treatment that they had to create new clinics all over the Netherlands for this new demand. To satisfy this new demand, there might be 250 or 300 who are getting puberty blockers each year now. So what evidence do we have on the outcomes? So the key landmark article was by De Vries et al. There was one in 2011 and one in 2014, where they showed this early Dutch cohort. They started off with 70 kids. By the age, in the second follow-up study, they looked at 55 just after they've had their surgeries. So they were still very young, aged 19 to 22, and they said these kids are doing very well, they've developed normally, everything is fine, and that provides the key basis for which puberty blockers are offered all over the world, just based on that one group of Dutch teenagers. There is literally no follow-up study ever been published after the age of 22. The only one we have, there's only one, literally only one, is that B was followed up again at the age of 35. Remember, B had been at the age of 20, they'd said B was doing great and was flourishing. But at age 35, B was depressed and had broken up with a girlfriend. Not surprisingly, she was sexually interested romantically interested in women, not men. She'd broken up with the girlfriend because of shame about his genital appearance and his feelings of inadequacy in sexual matters. So this long-term follow-up, was published in 2011, and I think anybody reading that would say this looks like a really bad outcome. But the Dutch were very happy with it, and everyone else in gender medicine seems to think this is a great outcome. And I should say the great irony is that shame about your genital appearance is one of the criteria of gender dysphoria. So they apparently cured gender dysphoria at the age of 20, but in that long-term follow-up at the age of 35, B was ashamed of his genital appearance. So there was one attempt to replicate the Dutch results, and that was done at the Tavistock, the GIDS, at the Gender Identity Development Service Clinic. And what they did is that they recruited 44 adolescents. They recruited them 2011 to 2014. These were aged 12 to 15. After a year, they immediately had some negative results. So the Dutch found positive results. The London clinic found negative results. So what they did was then not to publish those results. So they were suppressed. In fact, there's a conference paper that I dug up by colleague Carmichael, who was the director of the clinic. And she said in a conference of transgender clinicians, she said, our results have been different to the Dutch. So this was known not only at the Tavistock, but also by the Dutch themselves. But they were quite happy for that evidence to disappear until I discovered what was going on in 2018, 2019, and I called for the outcomes to be released. Ironically, I was the person who first published the comparison of the Dutch and English prospective studies, showed that while the Dutch did have good results, their English had they didn't have good results at all. Those results have now come to light, but we still don't know what the long-term, those are only results after 2 years on puberty blockers. We still have no idea what the long-term outcomes will be for the Tavistock cohort, and the Tavistock themselves never intended to collect any long-term outcomes. They say they can't follow up anybody over the age of 18, so I assume that we will never know what happens to those kids. Next slide. Yeah, so the wider impact of puberty blockers is important because it's true, and I think the devil's advocate would say that actually most kids don't go through, or most under 18s who go to a gender clinic don't undergo early puberty suppression, because the typical patient now is a girl aged 16 or 17, and so obviously early puberty suppression is not relevant for her. However, I would argue that this availability of these drugs have a really outsized effect on the kind of imagination of the transgender child, of this new kind of person who has come into being. So if you look at who is being featured in the media, it's always the kids who have got early puberty suppression, because they are the most photogenic and they are the ones that the cameras really like, and the news outlets like BBC and other kind of media outlets love to feature. Jazz Jennings is the most famous example in the English-speaking world. But we can also focus on, let's say in Britain, Jackie Green, who took gonadotropin-releasing hormone agonists at the age of 13, privately from an American clinic. Very quickly, within a few months, went on to estrogen. And of course, Susie Green, Jackie's mother, became the chief executive of Mermaids and became very influential in the transgendering of children. And you can see from that image how this fits into this idea of you can change sex, because here is someone who was born male who is now a beautiful woman and a beauty queen. Also, the availability of puberty blockers makes social transition feasible for the first time, early social transition. So, of course, it would have been ludicrous in 1990 to enroll your 7-year-old as the opposite sex in school, because it would become very clear as soon as puberty hits exactly what their sex is. But of course, the availability of puberty blockers means that you can now say, well, I can enroll my child as the opposite sex because we are able to, in due course, suppress puberty. So puberty blockers make social transition feasible, and of course social transition then locks in transgender identity. Kids who have been socially transitioned early can't really make a meaningful choice as to what they want to do, which direction they want to go in. And most crucially, I think it is kind of dramatically reconceptualizes puberty. Instead of puberty being a phase, and this absolutely essential phase that we all have to go through in order to move from childhood to adulthood, puberty becomes a kind of an optional choice, and indeed even as almost a disease. So De Vries et al. Say in trying to justify why they don't want to do a randomized clinical trial, they say, but disallowing puberty suppression, resulting in irreversible development of secondary sex characteristics. So it's now to allow puberty to proceed. And in fact, the ultimate outcome of this is, of course, to allow some children to stop puberty forever, become permanent, if you like, prepubescence, which is happening now in Australia, because when the kid gets to the age of 16, and the doctor says now it's time to go on to cross-sex hormones, you can't continue on puberty blockers now, and the child says, no, I don't want to go into cross-sex hormones, and I don't want to revert to my own sex hormones. I will simply remain puberty blocked forever. The child then at 16 has ability to consent to that, and the ethicists have said that that's fine, that the child can just sort of live in that frozen state forever, or for the rest of their life. Next slide. So before I turn over to Matilda, just to give you a sort of a snapshot from Horan, who was the Dutch endocrinologist who appeared on a television program seen by millions of people in Britain, called The Wrong Body. And he was extremely cavalier, as that documentary makes clear, because you see him being willing to prescribe puberty blockers to an English 13-year-old who he'd met only briefly, only for half an hour or so when making the documentary, despite the fact that Tavistock refused to give puberty blockers. He was quite willing to say, oh, I'll give you, he said to the mother, I'll give you a 3-month prescription. But even he expressed some reservations in this documentary. He says, we're very, very reserved about this treatment. Hormonally speaking, it's safe, but psychologically speaking, did we do the right thing? Do people of 13 never have second thoughts of what they're doing? But of course, they continued not being reserved at all and just rolling it out to more and more children in the Netherlands and throughout the world. Thanks. I'll turn over to Matilda now.
Thank you very much, Michael. I won't do questions to you now. I'll go straight on to Matilda and then we'll do questions jointly after both presentations. Over to you, Matilda.
Thanks, Helen. Thanks, Michael. Okay, my focus is going to be on the current state of the evidence and what it tells us. And the background to my work in this area is that I was starting to draft a book chapter on gender identity in teenagers. And I realised two things once I'd pulled together an initial summary of the research. So the first was that I was going to need to write a much longer piece first in order to distill it into a useful chapter later. So much has been written and you can't just look at 25% of the research and hope to understand it. The second realisation was how little information was available specifically for parents and other caregivers, which seemed like a huge gap. And this is what led me onto this series of papers for Sex Matters on gender identity in teenagers. My focus this evening is on what the research literature terms gender affirming care. And gender affirming care means that adults unquestioningly affirm teenagers in their chosen identity, and that comes with psychological and medical ramifications which accompany that acceptance. This kind of care includes medical intervention, and that, as Michael covered, means puberty blockers for younger teenagers, hormone treatment for older ones, and then surgery, which, at least in the UK, tends not to happen until adulthood. Medical treatment is built around an assumption that if a child believes they are of a different gender to their natal sex, it's their body that needs changing. And the underlying factors, so mental health difficulties, say, or being same-sex attracted, or the absolute vortex of social media, are seen to be secondary. And so too is the fact that teenage identity is constantly shifting. For many clinicians, researchers and activists, even to question the gender-affirming care model is heretical. But a careful assessment of the research that underpins it shows that it overclaims and arguably actively harms. I'm going to separate my analysis into physical and mental health effects. So if I were a clinician employing gender-affirming care, I would presumably want two main things. The first is to change a patient's body so that it aligns as much as it ever can and with a minimum amount of side effects with their gender identity. The second thing I would want is to reduce feelings of distress related to gender dysphoria, evidenced through improvements in patients' mental health. Could I have the first slide, please? Let's look at the physical impacts first. Leaving aside the question of whether I believe changing a child's physical body is the right thing to do, which I don't on current evidence, in my imaginary role swap as a gender clinician, I'm interested in whether puberty blockers halt puberty, which they do, and whether hormone treatment causes things like breast development in natal boys and more body hair or a deeper voice in natal girls, which, again, they do. But the side effects that go alongside these physical changes, as you can see on the slide, are significant. Many are irreversible. They range from the merely irritating, tiredness and acne, to the truly life-changing. Can any of us as adults truly imagine discovering that we can never have a baby, not because of an active choice or bad luck, but because of medical intervention sanctioned by healthcare professionals when we were below the age of majority? Similarly, while it might seem quease-inducing to think of young teenagers and sex, these teenagers will become adults. Can they understand what it means never to experience orgasm? And is this a reasonable factor in informed consent? Could I have the second slide, please? One key issue here is the inevitability of treatment pathways. 98% of children who start on puberty blockers go on to take hormone treatment, which has a more significant range of irreversible effects than taking puberty blockers alone. We don't know from the research yet what the cause and effect process is, but it's reasonable to speculate that children's gender dysphoria gets compounded by medical treatment, and having publicly committed to changing gender makes it much harder to change their minds, leading to this very high rate of follow-on treatment. Another crucial issue is detransition. We don't know how many children who medically transition later change their minds, mainly because long-term follow-ups are lacking. Even the most recent paper from a major Dutch clinic, which purported to show that detransition is rare, only followed people for an average of 4.5 years from intake, when an earlier research paper from the same clinic showed that the average time to regret was more than 10 years. The more recent paper also didn't specifically assess the proportion of patients who detransitioned. We do know, though, that there are an increasing number of detransitioners willing to share their stories, and the irreversible physical impacts they experienced lead to further cracks in the argument that informed consent is possible with gender dysphoric teenagers. Returning to my hypothetical gender clinician, I may have decided that the physical impacts and the consent issues are worth it in order to support my patient's mental health. Or indeed, I may have skimmed over the research that tells me about the downsides through no fault of my own, and I'll return to this point later. I want to be sure my distressed patient is supported to feel less anxious, depressed and dysphoric, and to have a higher quality of life. So what does the research tell us about the mental health effects of medical transition in teenagers? Could I have the next slide, please? Speaking now as a researcher and not as the hypothetical gender clinician, when I conducted my analysis for Sex Matters, there were 8 long-term studies on medical transition in teenagers that met some basic criteria, and one more has been published in the interim. These are studies that take measurements at different points in time. So they measure teenagers' mental health before they start treatment, and they also measure it later once they've been on treatment for a specified period. The idea is to see how their mental health in the forms of things like anxiety and depression shifts across time. You can see from the slide how many different approaches to do this were used over the 8 studies, which obviously makes any grouped analysis of them extremely challenging. I looked at these long-term studies to assess their quality and to work out if the data shows what they report it to show. I also looked at retrospective studies, and these are usually ones that ask adults to remember how they felt as teenagers, but I spent less time on them as the long-term studies are higher quality. Despite this, the first thing to note is that there were some serious limitations within these supposedly higher quality studies. Could I have the next slide, please? You can see on this slide some of the limitations, and it shows the 8 studies labelled as A to H. For me, I think the most baffling issue is the confounding of psychotherapy. And this means that the teenagers in the study were getting psychotherapy at the same time as puberty blockers or hormone treatment, but this wasn't taken into account in the analysis. If teenagers' mental health improves over treatment, is this due to the psychotherapy they received at the same time, or is it due to the medical treatment they received for gender dysphoria? And we have no way of knowing. Another important issue was the number of studies that had dropout rates of more than a third. The teenagers who were lost during the study could have dropped out because their mental health got worse and they found themselves unable or unwilling to complete a standard clinic questionnaire, or because treatment wasn't working for them. Again, we have no way to tell. These dropouts were actually included in the analysis in 3 of the 8 studies. So the pre-treatment results included children whose data, for one reason or another, wasn't included in the later results. The 9th study that I mentioned, and that's the one published since I ran my analysis, had some similar issues to the ones I've outlined on the slide. Could I have the next slide, please? Despite all these problems, which we might expect to lead to some over-reporting of positive mental health effects linked to puberty blockers and hormone treatments, the mental health impacts of gender medication in teenagers is minimal. This slide shows the results of an analysis I conducted comparing mental health outcomes of puberty blockers and hormone treatment with the placebo effect. There aren't any gender medication studies that use a placebo comparison for some good reasons. So I looked at medical trials of treatments for various mental health conditions in teenagers, for example, depression, bipolar disorder, and schizophrenia. I limited the analysis to those studies that use the same mental health measures as those used in the long-term gender treatment studies. You can see on this slide the effect size of the placebo, and this shows what happened to teenagers' anxiety, depression, quality of life, and psychological functioning when they took a placebo for their mental health condition rather than an active treatment. It's an imperfect comparison, but it's the best we have for the moment in this area. As you can see, the effect size of puberty blockers and hormone treatment on teenagers' mental health is no better than placebo. The headline picture actually makes it look worse, although we don't have enough data to know whether this picture is real or whether it's statistical white noise. Could I have the next slide, please? We can't, of course, talk about gender-affirming care for teenagers without mentioning suicide. Suicide statistics have been used by campaigners to pressure parents, clinicians, and policymakers into wholesale adoption of this model. The statistic they tend to use is pulled from one tiny and defective survey. While any suicides are too many, actual rates among gender-questioning teenagers are low. Michael has found a rate of 0.03% in the GIDS population in a study he published last year. In the 8 long-term studies I mentioned earlier, half looked at a desire to die by suicide, suicide attempts, and/or self-harm. Only one of the 4 found a statistically meaningful reduction in any of these areas over the course of treatment, and this single study didn't account for the psychotherapy that teenagers were receiving at the same time as their medical treatment. We therefore have no real evidence to say that medication for gender distress reduces feelings of suicidality in teenagers. Could I have the next slide, please? I also want to mention a side note on reported levels of gender dysphoria. This has serious problems in terms of how the tool used to measure it has sometimes been adopted, which makes the related data pretty meaningless. The studies that assess gender dysphoria tended to use something called the Utrecht Gender Dysphoria Scale, which, until it was revised in 2020, had 2 different versions for girls and boys. In its previous form, children were sometimes given the questionnaire linked to their sex when they first completed it, and they took the one linked to their chosen gender when they'd undergone treatment. In other words, a natal girl would take the girl questionnaire at the first measurement point and the boy questionnaire at the second measurement point. To take the example of natal girls, they were asked about things like discomfort around periods the first time they completed the questionnaire, but not the second. So if they felt uncomfortable about their periods, and who doesn't as a female teenager, this would accrue a negative score the first time they completed the questionnaire, but not the second. And similarly, the boy questionnaire asked about some things that are totally irrelevant to natal girls, like feeling discomfort around peeing standing up. The awkwardness teenagers might feel about their sex could therefore be edited out through the questionnaire version they completed later on. Interestingly, the only long-term study in my analysis that showed a statistically significant improvement in gender dysphoria flipped the questionnaires in this way. My hypothetical gender clinician then might be realising that there are serious issues with both intended outcomes from prescribing medical treatment to gender distressed teenagers. The physical effects are serious and some are irreversible, and the mental health benefits appear to be no better than placebo. If I were doing a cost-benefit analysis at this stage, I might be holding off on treatment at the very least until there's better data available. And this is the nub of the issue. The misreporting and loss of nuance in the research papers means that there's a huge and shocking lack of awareness about these problems. Part of this is probably due to the hangover of the no debate period. These findings historically have to be taken at face value, or you encounter some awful accusations. But there is also something peculiar to the repetition of these findings that means a shaky message becomes an accepted truth. Could I have the next slide, please? I've put some examples on this slide of statements relating to medical treatment and mental health in gender distressed teenagers. The third example is from the Standards of Care published by the World Professional Association for Transgender Health. The other three are from peer-reviewed journals: the International Journal of Transgender Health, Cell Reports Medicine, and the Journal of LGBT Youth, respectively. You can see that all these passages uncritically accept the prevailing narrative on mental health benefits. They are presented in order of publication. I'll read out the final quote for emphasis. The Standards of Care clearly state that withholding timely access to medical care from trans and non-binary youth comes with heightened risks of psychological distress and violence. For clarity, the original passage from the Standards of Care about violence relates to safety concerns in public spaces and is linked to uncertainty and to small-scale studies, but that's not the way it's presented in this write-up. Every time one paper summarises another, we lose a level of nuance and understanding. This is an example of what happens to original findings in the research literature, which often themselves are not presented accurately and with proper acknowledgement of quality. These original findings often get reported by one source and are then summarised again in a different form, and the meaning changes slightly each time, until you're left with echoes on the internet that suggest you're causing literal violence if you question the parameters of the model. The stakes are high when it comes to medicalising gender-distressed teenagers. We need clear-sighted appraisal of the existing evidence, an ability to call out poor research when we find it, and the wherewithal to capture better data in future. In England and some other places, challenges to the accepted narrative have begun, with strong indications that the future model of support for teenagers with gender dysphoria will look very different. Hopefully, as critical mass gathers behind the realisation that the research underpinning the gender-affirming care model has critical flaws, other countries will follow. Thank you. Back to you, Helen.
Thank you so much to both Michael and Matilda. That was absolutely fantastic and incredibly informative. Just to remind everybody that this is going to go on our YouTube channel, so you can watch it. And I think we might try to publish the slides as well so that people can read them easily on a full screen, because it's just so informative. Michael, I'd like to start with you. Several people have asked, both in questions before the webinar and during it, various versions of questions about numbers. So things like how many kids in Britain have had puberty blockers? Do we have any knowledge of what's happening outside the Tavistock, maybe via GPs or via private providers? And do you have any sense around the rest of the world? Like, probably not is the answer, because I think nobody's counting. But tell us what we know about puberty blockers and numbers.
So we know that at the GIDS, which of course covers all the United Kingdom apart from Scotland, we know that they've given puberty blockers to 1,000 kids. Most of those are over the age of 16. So what they would do is, like, let's say for a 16-year-old, they would give puberty blockers for a year before cross-sex hormones, or for a 17-year-old. So the GIDS would only give cross-sex hormones after at least a year of puberty blockers. About 200 and somewhat over 200 were under the age of 16. So that's comprehensive for England and Wales, apart from the NHS. What that doesn't include is gender GP and rogue operations who are based in countries outside the UK, who are giving puberty blockers. I mean, they're gender GP. Both the doctors involved, Helen Webberley and Michael Webberley, were both struck. One was struck off, and one was temporarily debarred from the medical by the medical council for example, prescribing puberty blockers for a 13-year-old after one Skype appointment. So we have got no idea. It must be. I mean, I assume it's hundreds, but I don't know. And of course, as the waiting list for and the NHS has increased, more and more desperate kids and their parents have resorted to private care. Outside, we really don't have any information from America. Often they will bill physicians will bill it as precocious puberty because they don't want too much scrutiny, or that perhaps in their state, if it's not a blue state, if it's not a Democrat state, if it's a Republican state, they may worry about it being reimbursed, or it may, and so they will bill it as precocious puberty. So we've really got no idea. It must be thousands. It must be many thousands. And the Netherlands, as I say, is about 300, possibly about 250 a year. And of course, all those numbers are increasing over time. There's no sign that they're leveling off.
And can I just stay with you for a moment, Michael, and ask just really to drill down to this question of whether puberty blockers are reversible, because this is the thing that's said about them. I mean, you've kind of hinted at part of the answer, but like a direct answer to, are puberty blockers reversible?
Yes, that was one of the key sort of rhetorical tricks that were used to introduce them and part of the Dutch protocol, was to say, well, actually, they're sort of a diagnosis and they're reversible. Of course, it's very disingenuous because, of course, if you took triptorelin, the drug that is used in the UK and the Netherlands, for 1 month and then stopped, I mean, that would have a negligible effect. And you came back when you looked at 5 years later, there would be no effect. Your puberty would have caught up. But that, of course, is not what's happening. What's happening is people are being put on for 2 or 3 years. And there's no reason to think they're reversible. There's no evidence that they're reversible. And moreover, animal experiments with sheep, randomized clinical trials with sheep, show that they're not reversible. So they gave sheep various cognitive tests, and then they put them on puberty blockers, stopped the puberty blockers, they went back to their natal sex hormones, and there were still differences in the way that they could, their spatial memory was different. So they're certainly not reversible if you use them for a certain amount of time. Also, as Matilda pointed out, that in actual practice, they're the sort of the gateway to cross-sex hormones. They're 95 to 98% of kids who start them will go into cross-sex hormones. So the sort of notion of sort of reversibility is itself kind of absurd, and there's certainly no evidence. In fact, the very fact that the NHS used to say they are deemed reversible. So they didn't say there's evidence that they're reversible, just that they're deemed. Who is deeming the deeming? We don't know. And of course, a few years ago, that the NHS deleted that language because they realised that it simply was not sustainable.
Matilda, I'll bring you in now, and there's a few questions I'll roll in together that are about parenting. So first, somebody wants to know about the books you're writing, what they're about, but also 2 questions about how parents should talk to children. One is just how early can parents talk to children about gender issues? And another one is, if you've got a parent who has sort of bought into the idea that there are trans children, that puberty blockers are reversible or so on, and the child thinks they're trans, is there anything that somebody could say to maybe make them think again? I mean, you may feel that that's not quite an appropriately phrased question, but something about communicating with parents who are on board with this narrative.
Yeah, okay, thank you. So to take the first question about my books, there are 2 books which are going to be published by Swift Press, who have just published Hannah Barnes's book today, which the first one is about 2 to 10-year-olds, and it will look at all of the research behind things like behaviour and learning and play, happiness and well-being, health, and what the evidence actually says about what makes a difference, rather than taking a kind of philosophical or belief-based approach. And then the follow-up book will be on teenagers. And then to take the second question about when to start talking to children about gender issues, I'm actually almost at the end of a series of interviews which will inform the final paper for Sex Matters, and that looks at kind of practical suggestions, practical ideas for parents in this area. And one of the things to come out of those interviews is that actually, if you are kind of before the point where your child might be starting to come across gender issues, it's quite good for them to understand. So to have those conversations as early as you like, really, so that people understand what the difference is between biology and identity, but also obviously children can be slightly vulnerable to the kind of general ideas that might be being passed around in the playground. So probably having some note of caution around respect for other people's ideas. Different people think differently about the issue, but as long as you kind of understand what it means for you and your own reality, I think those conversations can happen pretty early on. And then the final question, so this was, I think if I've got that right, Helen, it's about what you can do to persuade a parent out of the gender affirming care approach. I wouldn't agree that that's the right thing to do. I think that parents make their own decisions. There's always going to be stuff going on in families that nobody else has any awareness of. There's obviously a very hard call that you've got to make about kind of best interests of child versus what is right for families and parents. And I think an individual sitting on the outside can never make that call. That's not something that can be done. I think probably what needs to happen instead is that the prevailing narrative needs to change, and that means bringing into the light the problems in the research, hearing from detransitioners, kind of understanding more what the long-term impacts are, and that really happens at a societal level, not an individual level. And I wouldn't say that it probably wouldn't work anyway. I mean, if you've got somebody who's that invested in an idea and you're saying change your course, I don't think with the best will in the world anyone's going to do that.
Thank you. Really, really good answer. Michael, if I could come to you, and people are asking about what we know about how the replacement for GIDS is going to work. So maybe you could just give our audience a little reminder of what's happening to the GIDS clinic, what's going to replace it, and do we have a feeling that what they do there is going to be any better?
Right. So the Hilary Cass was brought in to review these services. She had the idea of breaking up the GIDS and putting gender. And I should say that there were two sort of impulses. First of all, there's, as we say, an exponential increase, which has no sign of reducing, and of kids wanting treatment. And so you have this massive waiting list. We have, I think, 7,000 kids on the waiting list. So you just have a clinic which is overwhelmed. And then, of course, there are also, on the other side, there are concerns about what's going on in terms of treatment and other treatments effective, and what's going on sort of safeguarding all the rest. So Cass says that we're going to break up the Tavistock. We're going to instead have more locally based hospitals that will treat under 18s. And the idea, which is a good one, is that people with different. So the problem with gender medicine is that if you're a gender medic, I mean, a kid comes in with any problems, they'll be solved by transitioning. That's what you do. Is there's a sort of a saying among the medical community: you diagnose the patient with the name with the disorder that is the name of your clinic. So if you're in a gender clinic, you diagnose everybody with gender dysphoria. So the idea was you have a variety of specialties. So somebody could say, well, this kid is more autistic, and we need to work. Or this kid has being bullied, or has depression or anxiety. So you work with these different sort of practices, and not just focus on gender, because of course the gender clinic focuses on gender. That's, I think, a great idea. What will happen in actual practice, I think, is very, very unclear. I don't know that anybody knows what's going to happen. You still have this massive demand, and the demand is not for therapy; it's the demand for medical transition. That's what the demand, or a lot of the demand, is for. You have private providers who are very, very happy to, and of course we know Susie Green of Mermaids just worked, is just now associating with Gender GP to sort of flog more drugs from as a profit-making concern. So exactly how that pans out, I don't think anybody knows at the moment. But yes, you kind of have an irresistible force meeting an immovable object.
Before I turn away from you again, Michael, there's a question from somebody who's watching us from Australia. So I think it's quite early in the morning there. Well done, whoever that is. Can you give a reference for that Australian person who is continuing puberty blockers to maintain pre-puberty? I mean, maybe we should just say that we'll pop that link in the follow-up email that will go out next week.
It's in my paper on the Dutch protocol. It's a citation to on the Dutch protocol.
So is this somebody who just never wanted to mature?
Yeah. So they're non-binary, and they took cross-sex hormones, I don't know, some 13, 14. Oh, no, sorry, they took puberty blockers. And then when they reached 16, the clinician says, okay, now you've got to either go back to your natal sex or you've got to go cross-sex hormones. And the kid says, no, I don't want to at all. And then they're 16 years old, they now reach the age at which they can make decisions about their future. And I should say, of course, this is going to be absolutely catastrophic for bone density, because they won't have accreted. We know that puberty blockers, the accretion of bone density, which is crucial for the rest of your life. You build up your bones by the age of 18 or whatever. Now, there is, once you take cross-sex hormones, there is some recovery, although it doesn't recover to where it should be. But the very fact this kid is not taking any cross-sex hormones and not going back to their own hormones is, a kind of what I think is extraordinary. But they say, well, the child has autonomy, so they're allowed to do it.
Okay, I'd like to bring you both back in, and we've a few questions from people more generally about academia, but also specifically about medical research. So people saying that it's normal in medical research for people to test and probe other researchers' ideas, sometimes quite viciously. It's not normal that we have a field like this where, there's just no challenging of the ideas. I mean, maybe I could turn to you first, Matilda, and are you seeing anything change in that, or is there anything that we can do to change that, to improve the challenging of ideas, the way the scientific process is meant to work?
I think there's something really unusual about this topic, which means that if you are on one particular side of it, you are not in any way open to challenge, no matter what the science and what the evidence says. And I think there's something that means that if you accept that somebody has an innate gender identity, then nothing else comes into it. And it's amazing because a huge number of scientists have kind of signed up to this idea. But I do think it's changing, and I think that there are more papers being published. I think Alison Clayton has written some excellent papers particularly on the placebo effect, and the Archives of Sexual Behaviour is a journal that's publishing more and more in this area, and obviously Kenneth Zucker, who you'll know, publishes a lot as well. And I think people are more open to discussing the ideas, but I think that's possibly changing more in England, perhaps, than it is in the United States or Australia so far. But it might be that they're going to follow. So if there's precedents set by England, by some of the Nordic countries, that other countries will be able to kind of come in behind.
And of course, Michael, you're one of the people who has published. So, how did you manage to do it, and what would you advise anyone else, or do you see anything changing?
Well, I sort of, yes, it is. There are only a few outlets that will publish, like Archives of Sexual Behaviour or Journal of Sex and Marital Therapy. I think it is. I mean, maybe in some able to do it because I wasn't in a clinical program. Maybe it would have been impossible to do that because in America in particular, this is now invested. It is the front line of the culture war, and any academic who even touches this issue from a skeptical point of view will face severe repercussions to their career. I think there is beginning a pushback, and there's the Society of Evidence-Based Gender Medicine, which I belong to, which is a growing number of physicians and clinicians and researchers who are very, very concerned about this and publishing work like Alison Clayton's work on placebo response. But it is difficult because, of course, we're sort of doing things at the edges. Like I managed to obtain original data from the Tavistock through the use of these freedom of information requests and complaints to the Health Research Authority. But of course, I don't have the kind of access to the data that the Dutch clinicians do or the Tavistock do, which would be really informative. I mean, for example, if you had, they have postcodes of where the kids come from, and it's very easy to look at postcodes and to see where is this big increase coming from. Does it come from more wealthy areas? How does it relate to school catchment areas? Does it come more from single sex schools? All this very basic kind of all sociological research to try to understand where this huge increase is coming from. They're just not done by the gender clinicians because they're not interested in finding out. In some sense, that's the incredible thing for me as a sociologist, that there's this amazing trend, and they're sitting on potential data to sort of shed light on that trend. They have no interest whatsoever exploring why that's happening.
Somebody asked, what is the current sex breakdown, as in natal sex at GIDS? It's about 2/3 female now, is that right, Michael?
Yeah. And everywhere.
Right.
I mean, every clinic is the same thing. And I should say that it's not because there are fewer boys showing up. There are lots more boys showing up, but then there are just a huge number of girls. So it's still more, the increase in boys has also increased massively.
Okay, we're coming towards the end of our time, but I think of time for one more question, but also a chance to ask each of you if there's any particular reflection that you'd like to add at the end. And the question is about people suing. Is this going to be the way that this all ends? Is that adults, detransitioners, maybe sue? If either of you would like to comment on that, or also to take the opportunity now, if you have any final thoughts on the event and anything final you'd like to say. Matilda, I'll turn to you first.
Okay, thank you. So, yes, I think the suing route has some potential, but I think it will probably combine with other areas as well. So I mentioned Hannah Barnes's book being published today earlier, and that looks at the Tavistock and what happened and what the implications are, and it's things like that, I think, that will combine together to hopefully create a wave of change going forward. So I'm not sure it ends with suing. I think that legal cases may contribute, additional information, people talking about it. This kind of event will all contribute. And I think hopefully it will all kind of form together in some kind of critical mass going forward.
Thank you. And Michael, what about you?
So I don't think this idea that there's going to be huge numbers of people suing is really very credible, because one thing is that it's very hard to sue the NHS. Secondly, detransitioners have really. I mean, Kira Bell was one extraordinary, courageous individual, but I mean that's really unusual, because detransitioners, I mean, people who go through the process already often have problems with anxiety or depression or, other kinds of issues. They go through the transition process. They realize, which of course itself is incredibly grueling, then they realize it was the wrong thing to do. You can imagine what a bad situation they're in. And quite naturally, they don't want to spend, 5 more years of their life going through the legal process. So I think in some ways, I'm not sure that it was beneficial for them to do that. So I think we can't necessarily rely on, as Matilda say, there's this great openness and critiquing the research. But also I think, listening to the stories of detransitioners is also very important.
Well, thank you both so much. That's been really incredibly informative. I'd like to say thank you to both my speakers, to Michael Biggs and to Matilda Gosling, who have both written about this subject at considerable personal effort and cost, and are contributing to the sort of openness that we need. And I'm going to say goodbye to them now and take the last 2 minutes or so of this webinar to just tell you a little bit more about a couple of things that we can offer at Sex Matters. So if I could just have the next slide, please. So this is a page on our website. If you go to Sex Matters and you look for resources or advice, you will find these very easily. It's a page we've put together with lots of different sorts of resources for parents, and in particular, the 2 of the 3 papers that Matilda has already written are there, but lots of other things as well, like what's happening in schools, how you can challenge your child's school to not be promoting this sort of ideology without any evidence. So that's all there. Please do read it, download it and share it with schools, share it with other parents, just share it with anyone you think is going to be interested in it. Next slide, please. So as Matilda mentioned, this excellent book by investigative journalist Hannah Barnes, who's a BBC journalist at Newsnight and who was one of the 2 journalists who brought the story of what was happening at the Tavistock to Newsnight a couple of years ago. Her book is out today, Time to Think, and it's a forensic analysis of how GIDS went so badly wrong. So yesterday, after a few days of talking in groups, we decided that we would buy about, I think, 120 copies of Hannah Barnes's book and send it to leaders of medical schools that have signed a charter by GLADD. It's a group of clinicians, and it purports to be opposing conversion therapy. But it defines conversion therapy both as attempts to change people's sexual orientation, but also as anything other than the affirmative model that both our speakers have talked about when it comes to gender, and also to professional bodies that have signed a memorandum of understanding on conversion therapy that similarly misanalogizes between gender identity and sexual orientation when it comes to conversion therapy. It took us 3 hours to find people to sponsor 120 copies. So it was probably our most successful campaign yet. And we're identifying the key decision makers that we think we need to get the book into the hands of, and we'll be sending that out in the coming days. So thank you so much to everybody who generously supported that campaign, which, if you blinked, you missed it. Next slide, please. So as always, I just tell you a little bit about what Sex Matters does. The aim is to campaign for clarity on sex in law, policy and everyday life. So we're UK-based and not for profit. And you can become a supporter by just signing up to give us £5, £10 or a different amount a month. And if you do that, you will receive our memo, but also other things that maybe early invitations to webinars and such like. But everything that we do is put online. Everything is freely available. And these webinars are all on our YouTube channel, and you can watch them or share them afterwards. And next week, we'll be sending an email out to everybody who signed up for this webinar, reminding them where they can see this again and asking them to share it, because I think this is the most important information that people can get out about how gender has gone wrong. So thank you all so much for coming tonight, and see you at the next one.